Okay, so our 2 hours. Let's get this started. Hmm. Okay, so then we need to discuss wrong labor, obstructive labor, dystocia, and fetal anomalies. We need to do this from page number 119 to 145, around 25 pages. So around 15 minutes it will take. Um, Around 5 o'clock I'll finish. After that I'll sleep for some 2 hours. I'll wake up and I'll study abortions, antenatal average, and assessment of fetal well-being and antenatal assessments. Okay, so obstetric labor is despite good contractions, arrest of progress due to mechanical factors leading to delivery caused by maternal, like CPD will be there. Most common pelvic tumors like ovarian and fibroids, cervical dystocia due to previous scarring. Fetal, you have malposition, occipiter posterior, deep transverse arrest, malpresentation, neglected shoulder, brow, or persistent mento posterior position, macrosomia, fetal anomaly, sydops, fetal ascites, tumors, conjunctions. All of them cause obstructed labor. So clinically, maternal is exhausted, dehydrated, tachycardic, tachypnea, and acidotic breathing will be there, and hematuria will be there. Abdominal examination is tonically contracted, upper segment will be there, lower segment will be stretched. Bandel's ring running obliquely over the uterus and raising up will be seen. Upper and lower segments will be sharply demarcated. Evidence of fetal distress, fetal heart sounds are usually absent. Fetal distress, fetal heart sounds absent. Okay. Upper and lower segment will be sharply demarcated. Bandel's ring running obliquely over the uterus and rising up will be seen. Tonically contracted upper segment, lower segment is stretched. Okay, vaginal examination. Vagina is usually hot and dry, and offensive discharge, vaginal discharge will be the cervix is fully dilated, maybe felt hanging loose, and membranes are absent. Membranes are ruptured. Okay, treatment, you have preliminary treatment, which is fluid electrolyte balance you have to maintain, and correction using dehydration, ketoacidosis. All of them should be corrected. Antibiotics, ceftriaxone 1 gram IV you can provide. If fetus is alive, then you provide immediate cesarean section. If fetus is dead, in modern days you do cesarean section. If earlier, when obstetrician were destructive procedure, you do destructive procedure. Okay, fetus is alive, immediate cesarean section. That's it. Okay, ceftriaxone antibiotic. Shoulder dystocia is a wide range of difficulty encountered in delivery of the shoulder. Delivery of the shoulder difficulty. Okay, head to body delivery time exceeding 30 seconds. Head to body delivery time exceeding 30 seconds defines shoulder dystocia, where risk factor is in maternal diabetes, maternal obesity, and fetal obesity, post-term pregnancy, and anencephaly. Fetal ascites also. And fetal obesity, that is macrosomia also will lead to shoulder dystocia. So complications, you have fetal asphyxia, brachial plexus injury, Erb's, Klumpke's palsy, humerus fracture, and sternocleidomastoid hematoma. Maternal features, you will have postpartum hemorrhage, cervical laceration, vaginal tear, perineal tear, uterine rupture, sacroiliac joint dislocation. Then diagnosis, you do definitive recoil of head against the perineum, turtleneck sign. There is recoil of the head against the perineum. Inadequate spontaneous restitution. Fetal face becomes plethoric, and failure of shoulder to descend. Management. So sequence of steps is called as shoulder dystocia drill. First line measures, which is immediately after recognition of a shoulder dystocia, extra help should be called, and maternal pushing should be discouraged. Maternal should not be pushed, as it may lead to further impaction. Liberal episiotomy to provide more space posteriorly. Fundal pressure should not be employed. High neonatal complication and the uterine rupture will be seen. Moderate suprapubic pressure can be applied. By an assistant. Okay. Above the pelvis, you can put pressure. Then you have to do McRoberts maneuver, which is flexion and abduction of maternal hip. Maternal hips is flexed and abducted. Then position the maternal thighs on her abdomen. You entirely push the thighs on her abdomen. Okay. Second line measures is done only if first line measures fail. Wood's maneuver, which is progressive rotation of posterior shoulder by 180 degree. The impacted anterior shoulder is released. So if anterior shoulder is impacted, you rotate the posterior shoulder 180 degrees. Third line measures done only if second line measures is failing, which is cleidotomy, fracturing the clavicle of the fetus. Symphysiotomy also can be done, dividing the pubic symphysis of the mother. Zanelli's maneuver is replacing the head of the baby back into the pelvis, followed by cesarean section. Zanelli maneuver, Wood's maneuver, McRoberts maneuver. Those three things you have to remember: McRoberts, Woods, Zanelli's. Three things you have to remember: symphysiotomy, cleidotomy. That's the only thing about anencephaly. Hydrocephalus is expressive. You really don't need to do this. It's very rare to find this type of thing. Anencephaly is due to deficit development of the vault of the skull and brain tissue with normal facial portion. Facial portion is normal, cranial vault and brain is not developed. Elevated alpha fetoprotein in amniotic fluid. Okay, then you have sonography at 10 weeks. Absence of cranial vault is seen and angiomatous brain tissue will be there. Angiomatous brain tissue. Complication: you have hydramnios, malpresentation, premature labor, tendency of post-maturity, shoulder dystocia and obstructed labor. Okay, there is termination of pregnancy should be done. Uterus is often refractory to oxytocin because of low level of estradiol, and prostaglandin vaginal dual PGE2 to be efficient in resistant cases during labor. There instead of oxytocin, PGE2 is effective in resistant cases, and shoulder dystocia should be managed by cleidiotomy. Okay. Prevention: folic acid supplementation 1 month before the conception, 12 weeks of pregnancy to about 12 weeks of pregnancy. Reduce the incidence of neural tube defect significantly. Then macrosomia, which is fetal neonatal weight more than 2 standard deviation on 90th centile. More than 2 standard deviation. More than 4,500 grams is macrosomia. More than Indian context is more than 4 grams. Okay, more than 2.5 is normal. Less than 2.5 is pathologic. More than 3.5 is okay. Causes like hereditary race will be there: maternal obesity, gestational diabetes mellitus, post maturity, multipara and male fetus. All of them are cases. Grading: you have grade 1, grade 2, grade 3, and that is 500 from 4000. Okay, and then diagnosis: disproportionate increase in fetal size, fetus is big, and ultrasound measurements of biparietal diameter, head circumference, arm circumference are done to estimate fetal weight. Okay, complication: fetal hazards due to suppressed dystocia due to cephalopelvic disproportion, shoulder dystocia, brachial plexus injury, asphyxia, meconium aspiration. Maternal hazards: you have injury to maternal soft tissue, vagina and perineum, and postpartum hemorrhage and perpural sepsis will be there. Management: prophylactic induction of labor early to reduce the risk of shoulder dystocia, elective cesarean delivery in diabetic mother especially. Neural tube defects: anencephaly, spina bifida, encephalocele. Then prolonged labor is a combination of first and second stage is more than 18 hours. More than 18 hours is prolonged labor. Cervical dilatation less than 1 centimeter per hour. Fetal descent less than 1 centimeter per hour for a minimum of 4 hours. Okay. Prolonging latent phase. Latent phase is preparatory phase of uterus in cervix before the actual onset of labor. So mean duration is 8 hours in a primi and 4 hours in a multi. But latent phase more than 20 hours in primi and more than 24 hours in multigravida is abnormal. Then prolonged latent period is not an indication for cesarean delivery. Okay, prolonged causes: it may be due to failure to dilate the cervix. There is fault in the power. Uterine inertia will be there. Fault in the passenger, contracted pelvis, shoulder dystocia, pelvic tumor. Fault in the passenger also may be there. then malposition, malpresentation, and hydrocephalus. So secondary stage, if it is there, sluggish or non-descent of the presenting part in the secondary stage is due to fault in power, passage, and passenger. Okay, uterine inertia, regional epidural anesthesia, and constriction in CPD, android pelvis, contracted pelvis, malposition, malpresentation, big baby. Okay. Definition. So prolonged first labor is regular uterine contraction but cervical prolonged latent phase is patients with regular uterine contraction, cervical dilation 2 cm but no cervical change in 14 hours. Active phase rest is pregnancy with regular uterine contraction, cervical dilated at 8 cm, and however there is no cervical dilatation in 4 hours. Okay, 4 hours, 20 hours in primary and 14 hours in multipara. Then prolonged secondary stage with regular patient pregnancy with regular uterine contraction, 10 centimeter dilation at +1 station, and no descent in 3 hours. Okay. Management. Prolonged first stage, you give hypotonic uterine contraction, you provide oxytocin. Hypertonic uterine contraction, you give morphine sedation. If contraction are inadequate, proceed to emergency cesarean section. Okay. Prolonged secondary stage, maternal pushing effort is to be cheered on. Then IV oxytocin to strengthen the contractions, and if the head is not engaged, proceed to the emergency cesarean. If head is engaged, try a labor using either obstetric forceps or vacuum extractor should be done. Then complications of third stage of labor. We are almost there. So types of PPH, you have primary PPH and secondary PPH. Primary is hemorrhage less than 24 hours, most commonly atonic. Hemorrhage more than 24 hours, most commonly retained placenta. Okay, less than 6 weeks of postpartum. Okay, causes of PPH, you have atonic, you have traumatic, you have coagulopathy, and other causes. Okay, atonic is imperfect contraction, retraction of uterus, musculature, postpartum, breathing continues. Traumatic is genital tract injuries, laceration of cervix, vagina. Colpor is ruptured uterus. Coagulopathy, thrombin is DIC and hypofibrinogenemia, and retained products of conception. Other causes, retained product of conception. Okay, predisposing factors of PPH. Atonic is grand multipara, malnutrition, anemia, fetal multifetal pregnancy, itamnus, preeclampsia, diabetes, intrauterine malformation, fibroid uterus, precipitating factor, prolonged labor, mismatched third stage, and inadvertent use of oxytocin. Traumatic PPH is instrumental delivery, vaginal birth after prior cesarean, phase to pubis delivery, precipitated labor, and macrosomia. Coagulation, you have abruption, sepsis, intrauterine death, severe preeclampsia, and HELLP syndrome. All of them lead to coagulopathy. Abruption, sepsis, intrauterine death, severe preeclampsia. Instrumental delivery, vaginal birth after prior cesarean, phase to pubis, precipitated. Okay. Clinical features, you'll have palpitation, tachycardia, weakness, sweating, dizziness, restlessness, and pallor and oliguria. Palpitation, tachycardia, weakness, sweating, dizziness, restlessness, palpitation, oliguria. Diagnosis is by shock index, heart rate by systolic BP. Heart rate by BP. Normal is 0.5 to 0.7. 72 by 120 maybe. Okay. SPP. Used as a guide to estimate the amount of blood loss, and more than 9 and 11 is intensive resuscitation is required. Obstetric shock index is during pregnancy, normal value is 0.8 to 0.7 to 0.8. OSI more than 1 indicates massive hemorrhage and needs for blood transfusion. Okay. First you have to do diagnosis of PPH. Palpitation, tachycardia, weakness, sweating, dizziness, restlessness, pallor, oliguria. Management of postpartum hemorrhage. Let's finish it off. Okay, so immediately we call for extra help. IV line, you provide 2 wide bore cannulas, send cross matching test, coagulation screening test, and ask for blood for 2 units at least, rapid infusion with saline hematocele 2 units until blood is available, catheterize the bladder and monitor BP and pulse and all. So feel the uterus by abdominal palpation. If it is hard and contracted, it's traumatic. If it's atonic, then you have to do other things. But hard and contracted, traumatic, exploration you do, and hemostatic sutures on the tear sites you have to do. Then if the uterus is atonic, you massage the uterus, add oxytocin, add injection methergine, and examine the expelled placenta. Oxytocin, methergine, first and second. Okay. If it still remains atonic, explore the uterus, blood transfusion you do, and continue the oxytocin drip. Okay. 10 to 20 units in 500 ml. 10 to 20 units you have to do. Okay. Then if the uterus is still atonic, and then you give methyl PGF2, misoprostol per rectally, or carbitocin. Okay. If it is still atonic, then you do uterine tamponade, where you provide a balloon tamponade by manual compression. You can do tight intrauterine packing under anesthesia. Any one of the methods you can use. Then if it's still atonic, surgical methods. You have to go stepwise. First you do B-Lynch compression and multiple square sutures, ligation of uterine artery and uro-ovarian anastomosis leading unilateral and bilateral, ligation of anterior division of the internal iliac artery. So uterine artery and utero-ovarian anastomotic vessels, anterior division of internal iliac artery, unilateral or bilateral. Angiographic arterial embolization you have to do with gelatin sponge, and hysterectomy very rarely. If the bleeding is controlled, then admit to ICU and see. Okay. And the documentation of procedure is to be done in this thing. Okay. So oxytocin you have to provide 10 to 40 units. Methergine is 0.5, PGF2 is 0.25, misoprostol is 600 to 10. Methergine you should not give in eclampsia, contraindicated in heart disease. Cardiac PGF2 alpha, hypertension, preeclampsia, here bronchial asthma, cardiac disease, renal disease. PGF2 alpha, misoprostol you don't give. Okay. Oxytocin is continuous IV, every 2 hours you have to give 15 to 19. Misoprostol you don't give. Okay. Placenta accreta is a condition where there is morbidly adherent placenta. Placenta adheres to the uterine wall due to partial or total absence of deciduous bacillus and fibrinous layer, Newberg's layer. It will be absent. So placenta accreta villi will invade deeper layers of endometrium. Deciduous bacilli do not penetrate the myometrium. Increta is invade the myometrium, do not reach the uterine serosa or bladder. Percreta is invade the uterine serosa and even bladder. Risk factor: history of operative interference, like previous cesarean section, previous curettage, previous manual removal, previous treated Asherman syndrome, and synctialized myomectomy. Multipara advanced stage more than 35 years. So diagnosis: transvaginally sonography. You will find visualization of irregular vascular sinuses with turbulent flow. Myometrial thickness will be less than 1 millimeter and absence of subplacental sinoluceal zone. Then Doppler imaging can be done. Complication: APH will be there. Uterine rupture before labor, postpartum hemorrhage, infection, uterine invasion of the uterus will be there. Management: partial placental accreta, remove the placental tissue as much as possible. Effective uterine contraction and hemostasis achieved by oxytocin. Total placental accreta, you have multiparous hysterectomy, nulliparous conservative approach, and the cord cutting the umbilical cord close to base, leaving behind the placenta. Uterine artery embolization or methotrexate, autolysis of adherent placenta can occur. Fine. We move on to secondary postpartum hemorrhage. More than 24 hours, less than 6 weeks postpartum, retained beds of cotyledon or membranes, infection and separation of slough, endometritis and subinflation, withdrawal bleeding following estrogen therapy, chorioepithelioma polyp, infected polyp, and placental invasion of uterus. Management is by supportive therapy, blood transfusion, administration of methergine, and administration antibiotic. Active treatment is exploration, retained products removed by ovum forceps, methergine. You have to provide sloughing wound, hemostatic stitches should be done, laparotomy should be done, and then cases of uterine rupture, you have to do hysterectomy. Okay. Third stage of labor, birth of a child to complete placenta and membrane expulsion and uterine contraction at the center. Complication, you have postpartum hemorrhage, retention of placenta, shock, pulmonary embolism, and uterine inversion. Retained placenta is not expelled even after 30 minutes after being born. WHO, it is 15 minutes. It may be separated, unseparated, and complicated. So, the three phases involved in normal expansion is separation through the spongy layer of decidua, descent into the lower segment and vagina, expulsion into outside. Interference in any of this will be resulting in retention. Most commonly, it is caused by gland multipara, over distension of uterus, prolonged labor, uterine malformation, morbid adherent placenta, and adherent incarceration following contraction. Complications may be hemorrhage, shock, pleural sepsis, and risk of recurrence. Management: separated and retained, you have to express the placenta out by control contraction. Unseparated or uncomplicated, you do bimanual placental removal. Uterine inversion is partial or complete turning out of the uterus caused by mismanaged third stage. Unseparated placenta delivered by cord. Crates method. Okay. First degree, second degree, third degree is this much. Spontaneous inversion in atonic uterus, placenta accreta, over distended uterus, prolonged labor, macrosomia fetus, uterine malformation, short umbilical cord, tocolytics, Euler-Dallos syndrome. So we have degrees: first, second, third. Dimpling of fundus will be there is first, still remains above the level of internal os. Fundus passes through cervix but lies inside the vagina. Endometrium with or without the attached placenta is visible outside the vulva. Clinical features: you have neurogenic shock. Bleeding will be there due to placental detachment before correcting inversion. Pulmonary embolism will be there. Pervaginal pear-shaped swelling in the vagina, cervical canal. Management: resuscitation and replacement of inverted uterus done simultaneously. Johnson maneuver, hydrostatic O'Sullivan maneuver, Huntington's repair, and Houghton's method. Okay, Johnson's maneuver. Fundus should be last to reposition. Part which comes out, that is fundus, should be last to reposition. After replacing, oxytocin should be given to promote contraction. Warm saline is to be done into vagina with labia opposed to prevent leakage. Vaginal balloon with fluid and inversion corrects on its own. Huntington's repair is traction on round ligament with Alice forceps to pull up the inverted uterus, and Houghton's method is incision in posterior uterine surface to bisect the constricted ring which prevents the reduction of inversion. Then uterine rupture, 10 marker. Complete separation of wall of pregnant uterus with or without expulsion of the fetus. It can be incomplete, not include the peritoneum, or complete, including the visual peritoneum. Presenting as vaginal bleeding, loss of electrical fetal heart rate signal, abdominal pain, and loss of station of fetal head. Surgical exploration of uterus and identifying the tear. Bleeding, loss of electronic fetal heart rate signal, abdominal pain, loss of station of fetal heart. This is rupture. Operation of pregnant uterus without expulsion of the incomplete is not including the peritoneum. Previous history of classical uterine incision: vertical frontal uterus scan and more likely to rupture than lower segment incision. Myomectomy if it was done. Exclusive oxytocin stimulation if it was done. Obstructed labor, external cephalic version, grand multiparity, marked uterine distension, manual placental removal, and abruptio placenta. All of them are risk factors. Management includes immediate delivery of the fetus is imperative. Uterine repair indicated in a stable young woman to conserve the fertility, and hysterectomy is performed in unstable or multiparous women. Uterine repair and immediate delivery if is imperative. So we did it. Here in page number 131. Around 15 more pages, and the remaining I can do it off after sleeping. It will take around 45 minutes more, but I finish it fast as possible. I need to finish. For plural, everything is important. So, be friendly as well. For shooting, I can skip. No, but wait, just read fast. Pharmacology is very important. Prostaglandins, misoprostol. Induction of labor is also very important. Bishop's chorea. Bishop's chorea, I want to remember that. Active management of labor, partography, call index, episiotomy, forceps, enters, cesarean, hysterectomy. It'll take 1 hour. God damn it. If I do this much, then I'm somewhat confident actually. This much, and antenatal ANC and all I've done a little bit, but I should have finished this earlier, man. I'll finish this at 5 only now. Once I finish it at 5, I'll sleep till 7. I'll sleep a bit if possible, and then I'll go on. Let's finish it off. Penial tear, big baby. Okay. These factors of perineal tear of laceration is big baby, nulliparity, outlet contraction, shoulder dystocia, forceps delivery, scar in delivery like perineopathy, episiotomy, and face to pubis delivery and precipitate labor. So rectal mucous membrane is a perineal body is a renal sphincter, renal sphism. Posterior vaginal wall skin is here, and degree of tear will be first, second, third, fourth, like this only. First degree involves only vagina and mucosa. Okay, posterior vaginal wall and mucosa. Second degree involves vagina, muscles of perineal body, and not involve the anal sphincter. Then third degree involves vagina, perineal body, anal sphincter, not involving the anal mucosa. Involves all four liver from vagina to anal mucosa, leading to rectovaginal fistula. Anal sphincter is involved, not the mucosa. Anal mucosa is involved, rectovaginal fistula. Okay. Recent tear should be repaired immediately following delivery of placenta. Delayed beyond 24 hours. The complete tear should be repaired after 3 months. First degree is suture repaired, not required. Second degree suturing is required. Third degree suture needed to avoid anal incontinence. Fourth degree rectal mucosa repair followed by anal sphincter repair followed by vaginal tear repair. All of them after 3 months. Cervical tear is a minor degree of cervical tear is inevitable during first delivery and requires no treatment. It is the commonest cause of traumatic postpartum hemorrhage. So causes iatrogenic, attempted forceps, breech extraction, rigid cervix, scar from previous operation, carcinoma cervix, then strong uterine contraction, precipitate labor, placenta previa, primary cervical dystocia. All of them causes cervical tear. Diagnosis: excessive vaginal bleeding followed by delivery. Exploration of should be done. Complication: deep cervical tear involving major vessels lead to postpartum hemorrhage. Broadly ligament hematoma may be seen. Pelvic cellulitis may be seen, and thrombophlebitis can be seen. The treatment: minor degree you have to give is invariable. Then suturing is done under anesthesia in lithotomy position. Suturing. Abnormalities of prepurum: you have prepurum mastitis, lactational nipple trauma, nipple crackling. SRS enters the breast ducts and lobules. Clinical findings: you'll find fever of variable degree, localized unilateral breast tenderness, erythema, and edema. Fever, breast tenderness, erythema, edema. Management is oral cloxacillin. Breastfeeding can be continued, and ultrasound imaging to rule out abscess if unilateral mastitis does not respond to antibiotics. You have to rule out abscess and antibiotic also. Okay. Puerperal pyrexia is temperature more than 100 degree, 38 degree oral on 2 separate occasions 24 hours apart within 2 to 10 days after delivery. Puerperal pyrexia is considered to be due to genital tract infections unless proved otherwise. Causes: puerperal sepsis may cause pyrexia, UTI, cystitis, pyelonephritis, mastitis, breast abscess, then wound infection, CS or episiotomy, and pulmonary infection like atelectasis pneumonia, septic pelvic thrombophlebitis, then recrudescence of malaria or pulmonary TB, pharyngitis, gastroenteritis. So lung crackling, atelectasis, ambulatory pulmonary exercises, flank pain, pyelonephritis, single IV antibiotic, gender uterus, endometritis, IV gentamicin, clindamycin, wound puncture, wound infection, dry to wet packs, pelvic mass, salvic abscess, percutaneous drainage, picket fever, fever in day 5 and 6, septic thrombophlebitis, full heparinization. Puerperal sepsis. Infection of genital tract which occurs as a complication of delivery is termed as puerperal sepsis. due to endomyometritis, endoparamentritis. Okay, risk factor: antepartum, malnutrition, anemia, preterm labor, rupture of membrane, immunocompromised, prolonged rupture of membrane more than 18 hours, and diabetes. Intrapartum hemorrhage, repeated vaginal examination, dehydration, ketoacidosis during labor, and traumatic vaginal delivery. Hemorrhage, retained placental tissue, prolonged labor, obstructed labor. Then, causative agents here: group A, hemolytic streptococcus; group B, hemolytic streptococcus, methicillin, MRSA, Staphylococcus pyogenes, E. coli, Klebsiella pseudomonas, Proteus, chlamydia. Temperature more, pulse rate is more, subinflation of uterus, constant pelvic pain, spread of infection, pelvic peritonitis, pelvis tenderness, parametriosis, pelvic abscess, septicemia, peritonitis, abdominal vomiting, rebound tenderness. All of them will be seen. Investigations: high vaginal and endocervical swabs for the culture, midstream specimen for urine analysis and culture, sensitivity test for antibiotics, blood total count, differential weight count, hemoglobin estimation, blood culture should be done, urea electrolytes, pelvic ultrasound, retained placenta, abscess, venous thrombosis should be done, cervical endocervical swabs, midstream specimen urine, and sensitivity to antibiotics. Management is piperacin, tazobactam, carbapenem, clindamycin, vancomycin, teicoplanin. Then surgical treatment for perineal wound, retained placenta product, pelvic abscess, unresponsive peritonitis, rupture, thromboemboli. Okay. Management of septic shock, fluid and electrolyte balance, respiratory supports to maintain the arterial PO2, partial pressure of carbon dioxide, circulatory support for which is dopamine or dobutamine, infection control with intensive antibiotic therapy, surgical removal of septic foci, and hemodialysis for renal failure. Basically my pencil stopped working, so another 15 pages to go. Yeah, subinvolution is impaired or retarded. It is called as subinvolution due to grand multiparity, over-distension, maternal ill health, cesarean section, prolapse of uterus, uterine retroversion, and fibroid, aggravated by retained products of conception, uterine sepsis. Symptoms are abnormal lochia discharge, excessive uterine bleeding, irregular clamp-like pain. Signs are uterine height is greater than normal for particular day of purpurium, and uterus is boggy and softer. Okay. Management: antibiotics in endometritis, exploration of uterus and retained placenta, pessary in prolapse or retroversion, and methadone to enhance the inhalation process. Okay, so yeah, I need to charge my pencil. I think I'll study from here onwards. I'll just study on my own. I'll just do it very, very fast. I don't think I can. I'm in a position where I can. I need to go to sleep anytime soon, and I'll study this tomorrow. Yo. Genuinely, I just. I'll go to very, very fast. I'll go through this and I'll leave it. I'm really not interested in studying pre-eclampsia and stuff, but I'll go through it once. Abortions though, I'll pakka go. Antenatal counseling I'll do. Okay, fine. Leave it. Enough of studying.